on the nephrologist's desktop. Therefore, whatever corrective actions need to be taken, it is possible to do it on a live basis. All of you are aware that CCTV is available in most hospitals. Now, typically CCTV is actually used as a deterrent for theft or security purposes. We have taken it one step further, and we are the first hospital in the country that actually monitors the hospital infection control using CCTV. So we monitor hand hygiene. This is monitored across healthcare professionals, and these emails are circulated, thereby educating them and bringing up the compliance of hand hygiene between patients amongst all healthcare professionals. This definitely decreases the incidence of infection. All our medical transcription and dictations are done over the phone, and we have automated it in such a way that it is easily picked up. We have an in-house medical transcription team that transcribes the discharge summaries and outpatient records. Therefore, all these records are digitized. We are one of the few hospitals in the country also having a central monitoring system, where you can see that across the hospital, all the refrigerators and freezers are monitored. We're taking it a step further, where in the operation theatre, the air conditioning, temperature, humidity, air exchanges are also monitored live, and any if the temperature or the humidity is low or high, this sets up alarms and immediate corrective action can be taken. This particular hospital has a lot of firsts in our country. The reverse osmosis plant, which is very, very important for the dialysis. Generally, most hospitals have an Indian plant, which is cheaper to purchase, but the quality of the RO water is not that very good. We have the RO plant from Fresenius from Germany, which gives superior quality water, gives longer life to the dialyzer, and more importantly, does not waste a lot of water, because the RO return water is decreased by around 15%. We also have the most advanced endoscopes for urology procedures, which is the flexible ureteroscope. We have the laser for urinary tract stones and for the prostate. After this meet, I would invite all of you to have a look around the facility. Please don't miss the operation theatre. We have installed on the operation theatre walls what is called as bioclad, which is silver impregnated ions PVC, which is supposed to decrease the infection or avoid it completely. It is much more easier to maintain. Again, this is the first in the country. This hospital in Rajajinagar has the bioclad operation theatre complex, which covers around 5,500 square feet, where there are 3 operation theatres and a state-of-the-art IVF lab. The IVF lab has been built according to the Assisted Reproductive Society guidelines of the United States, and once it gets operational in a month's time, it will be the most advanced IVF and andrology lab in the city. We have motorized cots throughout the hospital. We have special pressure sore prevention mattresses. Most of these equipment have come from UK, so we avoid stretcher movement. The cots move between beds and between facilities within the hospital. We have an advanced PACS system where the entire radio diagnosis is filmless and can be viewed on all the computers across the hospital. Keeping with view our fact that we are also an academic institute and promote all educational programs in the field of urology and nephrology, we have a state-of-the-art bidirectional audio-video link between the operation theatre and conference rooms. NU Trust is a part and parcel of NU hospitals and takes care of social service. It is a charitable wing where we reach out with compassion to the patients who cannot afford care. We've been doing this for many, many years, where patients who cannot afford to get treated for the urinary system disorders, we provide significant amount of subsidy. A lot of our team members who are the housekeeping staff, security, etc., all their children we educate. Some of them are in schools, some of them are in colleges, and some of them are actually finished and now are supplementing education for others. We have a lot of university and national board accredited health science courses, both at the graduate and postgraduate levels. Most of these details are available in the press note that has been shared with you. As the first NABH accredited hospital in the specialty of Nephro and Uro, I'm proud to say that there are more than 230,000 or 230,000 healthcare facilities in our country. And approximately only around 280 or 300 NABH accredited hospitals. And the Quaternary facility is the first NABH accredited hospital in the field of nephrology and urology. And that is the list of protocols that we have. We have more than 1,100 protocols across the fields, be it in medical or non-medical side. So therefore, we have embarked on a new journey from Padmanabhanagar, which is in the southern part of Bangalore. We have outpatient clinics in Amur and Krishnagiri in Tamil Nadu. This is the new facility that we would like to dedicate to our country today. This is at Rajajinagar, and we are going to start outpatient facilities at Hassan and Chikmagalur. We have also started outpatient facilities in the island nation of Maldives, where our doctors go once a month. What I would like to tell all of you is that nephrology and urology as a single specialty is not very common across the country. We have tried to set up an institute where there are excellent outcomes and our patients get treated with very experienced medical care professionals. Thank you very much for coming over, and please spend some time with us, and we will give you a guided tour of the hospital after this press meeting. Thank you very much.
Nephro-Urology is not just two specialties put together. It is a collaborative effort of many subspecialties which need to come together to provide the ultimate goal of appropriate and adequate health care to a patient who comes to us. Call upon Dr. Venkatesh Krishnamurthy, who is our chairman and the chief urologist of the hospital, to tell you about what subspecialty means.
Ladies and gentlemen, thank you for being here, and thank you for carrying forward a message of dedicating this hospital to the country. Thank you for coming to a new hospital, the hospital with a difference. What is this difference? You peel the orange and you find an apple inside. That is what we seek to present to you. You've already heard Dr. Prasanna talk about all the facilities that we have, the equipment that we have. We are second to none, essentially. We have all the equipment. But is that what makes the hospital? It is like saying, which bank provided the first ATM? That does not matter, it's of no consequence. Which bank provides the most ATMs now? That is what matters. Similarly, you may view this as a hospital, as a kidney hospital. Nephrology and urology, it's just the beginning, it doesn't end there. We have a host of other subspecialties, people who have trained in smaller and smaller aspects, finer aspects of this field to provide better service. And that is what we present to you as a symphony of our subspecialties. Our success lies in that. As you are aware, a symphony is an extended musical composition in Western classical music, consisting of different segments of music that are put together in tandem to provide music that touches the very core of your music sense. NU Hospitals provides the same in the medical field. Very lightly put, it is said that a specialist is somebody who knows more and more about less and less till he knows everything about nothing. We are not going to hold hog over there, but if you see that board over there tells you the differences and the different segments of each of these presentations. We are not just a good hospital, we are striving for excellence. A good service is climbing the wall and sitting on it. An excellent service is climbing the sheer face of a cliff to be there. And that is what any hospital has done in the past so many years. We have put in extraordinary amount of effort over the past so many years, segmenting our services so that each of these musicians in this orchestra provides the best and contributes to the whole. Pediatric dosa is about the dosa and not about the tawa. Gundappa's hotel is about the sweet and not about the location or its history. Ambur biryani is about the biryani and not about the goat. Similarly, NU hospital is about its services and not about just the history. You will see testimony to the kind of work that we've been doing over the past so many years. And it is not just about the doctors. When we talk about the symphony of our medical services, it is not just the doctors. Doctors are the front face of this hospital. There are plenty of other people who have also been part of this symphony. Urology has so many segments. Nephrology has so many segments. A lot of it is preventive, so that it's not the point to say I've treated the maximum number of patients. But we also have our nurses who have been trained in specialties of urology, the first of its kind in the country. Prasanna has already listed to you several of our firsts. This is yet another, and there's a huge amount of recognition for that, because you're all aware, when you go see a doctor in the clinic, he spends just 5 minutes with you. If he's kind, he'll spend 10 minutes with you, and if you have a lot of influence, he spends 15 minutes with you. But the other 23 hours and 45 minutes is taken care of by the rest of the hospital staff, and these are the other people in the orchestra that we are providing this medical service. It starts with our nurses who are the immediate paramedical support, and these urology nurses are trained to such an extent that they are in demand in other parts of the country and in other parts of the world. Our technicians are also trained to such a degree. And all this, if you come, this sort of welcome and the presentation and the professionalism starts from the very time you enter the front doors of our hospital. And that is what we seek to serve you. And how are we serving this? We are serving this in the palette of blue. If you see our logo, that's very white and blue. Blue is the color of confidence. Blue signifies faith. Blue signifies cooperation and coordination. It is not just my own pigment imagination. Blue is the most popular color. Blue is the sign of the UN. Blue is the color of UNESCO. Blue is the color of NATO. Blue is the color of the European Union. NU Hospital strives to provide our services, this entire symphony in a palette of blue. And I'm sure when you carry this message, you will find that what we have said so far is only bearing of this truth on a platter. Thank you very much.
Take you through all the subspecialties of urology and nephrology. We're going to have very brief presentations which will highlight some of our very poignant and success stories which we've had with our patients. Each of the speakers here will tell you about one of his specialties which he or she specializes in. Call upon Dr. Prasanna to first make his presentation.
Hello again. I am a pediatric urologist. Pediatric urology is a very, very specialized field which deals with correction of congenital anomalies of the urinary tract, reproductive system, and the testes. There are very few pediatric urologists in the country. A lot of them go to pediatric surgeons or general urologists. This is an emerging specialty in our country, though in the West it has already moved on to an extreme level of subspecialization. I'll be just around 3-4 minutes, but that's a front view of the urinary tract, where you have the kidneys, and then you have a small tube that connects the kidney to the bladder, which is called as the ureter, and then you have the bladder and the genital organs. That's a side view. I'm giving you a little brief on anatomy because a whole lot of my colleagues are going to talk about the urinary system. Our hospital, NU hospitals, takes care of the kidney, the ureter, the urinary bladder, the prostate, the urethra, and the testes. So this encompasses the entire genitourinary system, both in the medical and surgical specialties. We had a 12-year-old boy who presented to us around 5 years back. This was a boy who was leaking urine since birth. He had a rare condition called as epispadias, where the front covering of the urethra, that is the tube which connects the bladder to the tip of the penis, was missing. And therefore, this particular child was leaking urine from birth. By the time he had seen us, he had undergone numerous surgeries, approximately 4 surgeries. He was from one of the villages near Gulbarga. Extremely intelligent chap, very high IQ, but he had become a social recluse, dropped out of school. The point is, none of the children in the school were willing to sit next to him because of the smell of urine. And the teachers had banished him to the back of the class. So this was the boy who came and met us around 5 years back. And that was the condition that he had. That is the lower abdomen, that is the penis, and you can see that the upper portion or the covering of the tube is completely missing. Because of this, he also had a defective urinary sphincter. The fact that all of us are able to control urine and go and empty our bladder at a socially acceptable place and time is because of the valve that we have at the exit of the bladder, which is called as the urinary sphincter. He had a defective sphincter. The sphincter itself was non-existent, and therefore he used to continuously leak urine. After thorough evaluation and counseling, we counseled the parents and the child. He underwent a very complex 6-hour procedure called as augmentation ileocystoplasty and a Mitrofanov catheterizable conduit. What you can see here is that the upper portion of that urinary tube is missing. And this is a pictorial representation of how we increase the bladder capacity. We take a segment of the small intestine, fold it upon itself, achieve end-to-end continuity of the small intestine so that its functions continue, and then we put a patch onto the urinary bladder and increase the bladder capacity. Because one of the first things why he was leaking is he didn't have adequate capacity. His bladder capacity, for a 12-year-old should be approximately 180-200 ml, but he had only around 40 ml. So it is like, overflowing. So we were able to achieve increased capacity. And then what we did is we fashioned the tube between the bladder and his abdominal wall, somewhere near the umbilicus, where he could catheterize the bladder and empty at his convenience, generally around 3 to 4 hours once. So this was the operation that was done. That is approximately 3 weeks after the surgery. Now, this child for the first time became continent. He did not leak urine any longer. And instead of, like all of us do, go to the bathroom and pee, every 3 to 4 hours, he passed in a catheter and empties his bladder. That's how he emptied the bladder with this tube. He's 17 years old now. He keeps in touch with me with WhatsApp. That's his WhatsApp image 2 days back. told him, can you send me a picture? So he sent it to me in WhatsApp. Very intelligent, very happy. He comes for his yearly checkups. He's doing his ITI first year now. He's looking forward to a bright future. The most important thing is his kidney function is normal. He does not leak any urine. And you know what is the question he asked me? He said, nobody in my village knows that I have this procedure. You're telling me that the press is going to come. Will they reveal my name? I said, no, definitely not. So he keeps talking to me once in a while. I believe that as specialized centers, these are the stories that we carry forward and we make a lot of difference in these kids' lives. Thank you very much.
Call upon Dr. Venkatesh now to take you to another saga which will probably bring you to tears. Thank you.
So you're going to listen to a lot of stories about specialties that even in the medical profession many people do not know exist. And I'm talking of children with spinal deformities when they are born. And this is the worst punishment that parents can have. Gauri, that is the child, name not changed because she wants to share her success with everybody. She was a wonderful gift to her parents when she was born, but unfortunately, she has this kind of tumor at the back. That is the nerves from the spinal cord coming out, as a result of which this child could not stand, of course could not walk, could sit only with support, could not pass urine, was leaking urine all the time, and was also unable to control her stools. Which parent wants a child like this? Unfortunately, in this family, the next child born was worse than this. So the mother, the father, from a very lower middle class family, had to manage a child, 2 children like this. When they came to us, we said, we'll take care of this. The neurosurgeon operated on this child, but that was it. So when somebody specializes, then that doctor takes care only of that specialty. So the neurosurgeon operated on the spine, closed this, whatever, removed all those nerves and then closed it. But that didn't help the child. Everything else that I spoke of, inability to walk, inability to stand, inability to sit without support, inability to pass urine, control urine rather, continued. And that's when they came to us saying, thinking that this was only a urinary problem, will you set it right? Obviously not. So here you see pictures of only a smiling parents and smiling child. All the crying was happening within the consultation. We had to take care of not only the bladder, but the bowel. Because the muscles were not active, then the bones did not grow. So she had to undergo surgeries for the bones to make her stand up with crutches. She had to undergo rehabilitation, psychological counseling. So when we talk, this is the symphony that we talk about. Here we are not taking care of an organ, but of the entire patient around that organ. And each time, this child, we had to go talk to the school to say, move her class to the ground level because otherwise the toilet was on the 2nd floor of that school. We took care of this. The care extended to this patient was from that level. And this girl had the grit and the parents had the determination to see her through. Each time we did something like this, the family would go on a holiday, and you can see in this, the child has a walker. She used to go around with the walker, always confident that we would help her sail through with all this. From the walker, she graduated to these crutches. What you don't see as well is that she's wearing special boots, special braces for the knees, to straighten the knees so that she could stand up. She went on to finish her engineering. Even in the engineering college, we spoke to them, but it's a huge college, they could not manage to move her class close to the toilet. But over the many years, she is not incontinent, she is not wet. She has control over the stools. She can walk with support. Looking at this, you would believe that she's leaning on the car, but the picture is of one person who does not need our support anymore. And then she wanted to be independent, so we put her on to somebody who would modify her car. So after she finished her engineering, she went for a master's in UK, came back. I put her on to somebody who would modify a car for her, and this is how she travels to her car. She's modified the inside of her car completely, drives independently, and is as dangerous as anybody else on the roads of Bengaluru right now. She's working in a software company, very happy, and this set of flowers was to her to enhance, because she enhanced our reputation. Thank you.
We'll get to hear more such stories as we go on. I call Dr. Manish right now, who will tell you about another similar such case.
Good afternoon. For long years, we've been doing renal transplant. And the question I asked myself was that of all the people involved in the transplant, who are the real, or who is the real hero? So there's this 40-year-old gentleman who's going around working in his field, completely healthy, gets a snake bite, manages to survive, but ends up with renal failure, and the kidney packs up. So in India, we still have big joint families. He had a reasonably good family support. The elder brother came forward and donated his kidney. The transplant itself was successful, and he did reasonably well, recovered. However, there was a slight misconception. We thought that we had sent back a reasonably healthy fellow who was fit for all his day-to-day activities as long as he took his medicines. He unfortunately perceived himself to be Superman and decided that I do not need any further medications. He stopped his medications after a few years on his own, and the kidney struggled for some time, and finally we were back to square one. Now, when he started developing symptoms, he came back to our nephrologist, and this was how our nephrologist reacted. Very angry, and believe me, when Dr. Dilip gets angry, he gets really, really angry. And we did not know what to do. This was an irresponsible patient. He had wasted one kidney. And we debated whether we should consider him for a second transplant at all. But we were surprised very pleasantly at the phenomenal family support that he had. And a second brother came forward, ready to donate his kidney. So we had a long talk with the patient, and he agreed that this time around he will be responsible. And the second transplant was done on the left. Technically, this is a slightly more difficult procedure and than doing it on the right. But again, things went well, and the patient is doing well. Now, in a transplant, there are 6 or 7 different groups of people involved. There is somebody who removes the kidney, who is known as a donor surgeon. He feels that because he did his job well, the kidney is working well. The donor anesthetist says that because I was good, the kidney is doing well. Similarly, on the recipient side, the transplant surgeon feels that I've done a great job and the kidney is doing well. The transplant anesthetist feels that her job was the best. The nephrologist also, of course, always thinks that they are the only ones taking care of transplant patients. So all these people are involved and everybody's input goes. A mistake at any of these levels could have caused a damage to the kidney. But the real hero of the transplant program is the completely healthy individual who, simply because somebody else in the family has developed renal failure, decides to donate his kidney. And it is the donor who is the real hero of any transplant program. And we do not look at donors for a very long time. We look at the recipients and we think of the recipients as our patients. But I think all due credit should go to the donors. And today, any hospitals would take this opportunity to salute every spouse, every brother, every sister, every mother, every child who has ever been a life-related donor. Thank you.
As Dr. Manish pointed out, the heroes are the donors who actually donate the kidney. We have for you our renal transplant recipient, Mr. V.R. Iyengar, and his brother, Mr. Chellakumar Bird, donated the kidney to him. This happened about 13 years back. You can see that he is well. I just invite him to say a few words.
Ladies and gentlemen, it's a great privilege for me to be here to share my experience as a recipient, which happened during 2002. And at the outset, I must thank the entire team of doctors here and the donor is my brother sitting here.
A big hand for it.
As the doctor rightly said, the entire credit must go to the donor. And the recipient is only the recipient. But at the same time, the recipient also has got a lot of he has to take care, a lot of care has to be taken by the recipient also to maintain. As the history goes, it was during 1998 when I returned. I was working as senior manager in Rajajinagar. I worked in 40 years of food service and retired in 2013. And when I was working in North India in Agra for the first time, I had swelling on my face and also fetal edema. But the doctors there did not diagnose properly. And in 1998, when I came back, I was taking treatment with a diabetologist because I am diabetic for the past 25 years. Probably due to uncontrolled diabetes and also the hypertension. Because these two, that is hypertension and diabetes, we have to take care. We can call them as faithful companions in our systems. And whenever we have both, we have to be doubly careful. Probably, what I guess, it was only due to uncontrolled and unmanaged diabetes and hypertension, the loss was to the kidneys. And in 2001, probably, I visited PDF, it was called as Bengaluru Information Time. And for the first time, I met Dr. Rajajinagar. And when the renal tract test was done, it was diagnosed as almost it was a chronic renal failure. Then I was put on some medicines for 6 months. Thereafter, the creatinine level was going up. It just around 5, and the doctor said, your kidney function has come down to around 40 to 40%. And in 2001 end, it was diagnosed as PSRD, that is end-stage renal disease. And any time it may collapse, and you have to be prepared. You may have to be put on dialysis, or another alternative is, if anybody is ready to donate a kidney, you can be on the safer side. And that is the best problem. Then immediately, you will not believe, as doctor was explaining, another family whom he quoted. My family also, we have 5 brothers, no sisters. All my 4 brothers, they came forward, I will donate my kidney. But the best suitable kidney was from my younger brother, who is 3 years younger to me. And actually he agreed, and immediately we were put on different tests. And in 2002 July, on 24th July 2002, the transplantation took place. And since then, I am hale and healthy. But the only thing is that the surrounding people may discourage me, or they go on telling without knowing anything about the kidney or its functioning. Many people mistake testicles as kidneys. If you ask people to donate, in Canada they will say, "Sir, donate ಮಾಡಿದ್ರೆ ಮಕ್ಕಳೇ ಆಗಲಿಕ್ಕಿಲ್ಲ ಸರ್ ಅವರಿಗೆ." It means they do not know what is the kidney and what's it. So at least basic knowledge about kidney, its structure, its functioning should be, we should bear it in mind. So my experience after the transplantation is very, very good. I am leading a very, very normal life. Only thing is that, day-to-day life, we have to be very, very careful, especially the treatment, the post-transplantation treatment and health care as prescribed by the doctors. If we take care, definitely we can take a normal person and we can lead a normal life. And since we are put on immunosuppressive drugs and other addict factors, that is antidiabetic and antihypertensive drugs, we are prone to catch any kind of infection much, much faster than a normal person. That is why a better care will prevent you from any kind of infection or that. Right from the day 1, that is from 24th July 2002, I have not gone to any hotel, I have not taken even a sip of water outside. Whatever is prepared at home, for that hats off to my wife, as Dr. Dilip will be always telling, a taskmaster is there at home, who will take care. Right from that day, even the utensils which I use every day is boiled, is sterilized in the morning, and only the sterilized utensils I use, so that most of the infections can control their itself. And food and water, we must be very, very careful, because most of the infections are carried by these 2 factors, that is food and water. Only homemade food, boiled food, hot food, and the boiled cooled water. Whenever I go outside, I carry the food and water which is sufficient for the whole day. Whether it is useful or not, I always carry that. And when I was working in the bank, most of the people discourage me. Why don't you take VRS? You can be healthy at home. It is not so. You will not be healthy at home if you are without work. Your mind be engaged, your mind should be engaged. And you can lead your life like any other normal person. Then people said, don't drive the vehicle, don't go around outside. It is also not true. You can definitely go outside and you can also drive the vehicle. I even now I am driving my car, four-wheeler, independently, without any problems. And regarding this hospital and doctors, I must say, Dr. Venkatesh Krishnamurthy was telling it is second to none. Yes, it is definitely second to none. And the entire team of doctors, really amazing. And it is one of the best hospitals which I have come across. And I have referred many of my friends to this hospital for better care. And the theory of professionals, the theory of profession of the doctor says, I treat, he cures. But for me, they are the living, visible gods. And even at midnight, 1 o'clock or 12 o'clock, 1 o'clock, also I have all the doctor work right phones. And I had a very good experience. The doctors immediately responded. And so far, I have not taken even a Crocin tablet without consulting the doctor. This is very, very important. Self-medication should be totally avoided. And the medication, Dr. Snow was telling about the second transplantation, is only because the patient did not take medicines properly. Yes, even if you miss the tablets or the medication for 2 or 3 days, it will have a very, very adverse effect. This was told to us in the beginning itself during the counseling. And I am following it very, very correctly. Even I have fixed up the timings for taking the medicines. Morning 8 o'clock, 10 o'clock, afternoon 2 o'clock, then again 8 o'clock, and before going to bed. Like that, I have spread the timings for taking the medicines. And also the follow-up. The follow-up is very, very important to the doctor. I even mentioned the dates. February 3rd, I met the doctor last. Then he said, after 1 month I will see you. Again on 3rd March, I fixed the appointment. Like that, because the doctors say, I treat, he cures. But at the same time, the patient should also cooperate with the doctors. And the patient's responsibility means to take care of himself is always there. The doctor says, definitely, whatever we are doing is only 50%, the other 50% remains. And one more thing regarding donation of the kidney. Most of the family members, they do come forward, but last moment they go back. This is not correct. Even the person who donates the kidney can also live a very, very normal life. And my brother is very much here. He will also speak about his experience. And regarding the hospital, this new best. This hospital, they have done, they have gone into the public on the eve of this World Kidney Day. I wish this hospital should also help most of the patients here. And I thank all the doctors here, the team of doctors, and all the staff of the Kidney Hospital for giving me an opportunity to share my experience with you. Thank you for hearing. Thank you.
We'll quickly go on to a couple of other specialties which we need to showcase. I'll call upon Dr. Prabhu to make his presentation.
flight of a newly married male who had acute urinary retention. He goes to a nearby clinic and they try to pass a catheter, like what is normally done, but the catheter doesn't go in. So he comes to our hospital. The reason the catheter doesn't go because there's a block in the passage. The part from the bladder to the external urethra. So we put a catheter directly into the bladder, so his retention was relieved. Then we did a couple of tests and we found that he has a long segment stricture in the urethra. We operated on this patient by taking a graft from the oral mucosa. This is how the surgical step. We open the urethra and we put a patch of the oral mucosa below. After that, he was able to pass urine like any other normal individual. He's under follow-up with us for the last 4 years, and this is the picture before and after the operation. It will be a little irregular, but it is wide open. Talking another patient with a female urethral stricture. This is how the lower part of the female genitalia look like. This is the urethra, the uterus, and the posterior part and the back part is the rectum. This lady was told to get dilatation, that is, pass a tube in the urethral passage every 6 to 1 year. And she had got this done for the last 5 years. And it was very horrifying experience for her. So she came to us to get further treatment. So we did the similar procedure like I showed in the male patient, just taking the graft from the oral mucosa. And after that, you can see the difference. Thank you.
So keyhole surgery is what everybody is after nowadays. They all want smaller and smaller incisions and larger surgeries to be done through the same. Just take you through the history of one particular gentleman who came to us. A 47-year-old farmer from nearby Bangalore came and visited us. He had already gone 2 or 3 hospitals earlier, and he was having fever for the last many days when he came and saw us. And what they had all told him there was, oh, you have a few small stones in your kidney that needs to be taken care of, and you'll be free of pain and fever. And they made him undergo a lot of tests elsewhere. He knew that he had kidney stones since the last 4 years. In fact, he had taken a treatment called, what probably all of you have heard somewhere, called blasting of the stones. So basically it's called lithotripsy, where we break the stones in the kidney using a specialized machine. We also leave a plastic tube inside the kidney in some of these conditions. Basically we want the stones to pass down, not cause any block, and so that the patients are pain-free. Now imagine this was done about 4 years ago, and when we did the investigations, this is what we found. And he was horrified to know that not only were there stones in his kidney, he had pieces of this plastic tube which had broken and had been left behind there. And all these pieces were coated with stone. So he was actually quite shocked to know about it, and nobody had told him after being to 2 other places. He had already got a CT done. And we went through this CT, we were alarmed to tell him, and we told him that he also has a small tumor sitting on top of his kidney. So he was even more shocked. He said, okay, the first shock was about having pieces of plastic tubes inside your kidney with stones. And the second shock was that he also has a tumor sitting in his kidney, which nobody had told him about. And this is a very specialized tumor. We call it a pheochromocytoma, very big name. But just remember that this is in a particular gland called an adrenal. Basically, this produces some medicines or chemicals rather, which either makes you run away from a stressful situation or you turn around and face it. But in most of us, when these chemicals are produced in large quantities, they can cause huge amounts of fluctuation in blood pressure. In fact, had this patient been subjected to his stone surgery elsewhere without treating this tumor, very likely he would have died. So imagine the shock to this patient that we told him, yes, Now you have an additional tumor in your kidney or other sitting on top of your kidney, and in addition you need to undergo surgeries for removing your stones. So he was actually overwhelmed by the number of surgeries which he needed to undergo. So that's when we decided to offer him this very advanced surgery called laparoscopic surgery, which all of you know of. In particular, what we call as retroperitoneal surgery. Now, this is a figure which you can see here. This is the whole stomach. In your regular keyhole surgery, we make small little punctures inside the abdomen. We look at whichever diseased organ is there and we operate. Now, retroperitoneal laparoscopic surgery, which is what we have offered to this patient, is an even more delicate and skillful surgery where we make space around the kidney. This was designed by an Indian, this surgery, and fortunately or unfortunately is not very well practiced anywhere. And I'm proud to say that NU Hospitals probably is the only place in Bangalore which offers this on a regular basis to most patients. So we made this space. It is not very easy to operate. To just give you an example of the kind of space we operate in, if you assume that this entire earth is the space you get inside your abdomen when you're doing a regular keyhole surgery, this is the size of space we get when we're doing retroperitoneal laparoscopy. So about the size of Mars, 1/3 the space. And in that, we're looking at a structure which is about 100 space which is available inside the abdomen. And the kind of skill which you need to operate is extraordinary. Believe me, this is exactly how it is difficult. That's the Melbourne Stadium. Hopefully, we'll be there at the end of the month. And if that is the kind of ease with which you can operate in regular keyhole surgery, the skill set required is more like gully cricket. We all know what our cricketers tell us. If you're extremely good at gully cricket, you can probably do anything anywhere else in any other field. So that's how difficult retroperitoneal laparoscopic surgery or this advanced keyhole surgery which we do. So we went ahead, offered this to this patient, removed that tumor which was there in that gland, and this is how he looks 9 months later. That's his scar. You can see it's just about 1 inch across. And once we removed this tumor, we went ahead and offered him surgeries for the rest of his kidney stones. We removed all his stones, though we told him that it would take many stages to remove his stones, just because he said, could you bring it down to one surgery? So in consultation with that anesthetist who said he's reasonably fit, you can go ahead and finish all the surgeries, we were able to manage all his stones, pieces of plastic tube all in one sitting. Today, he's an active work, he works in his own farm, he has no pain, he has no medications, he has no stones. Thank you. I would now call upon Dr. Dilip to start you on what we call as nephrology, and we'll talk about preventive nephrology.
Good afternoon, everyone. From the individual stories, I'm going to take you to the great Indian story now, which will work with rapid attention. At NU, we just don't stop at just treating you, but we look into the preventive aspects and make sure that you don't get into such trouble as Mr. Iyengar said. 2 devastating diseases, diabetes and hypertension, and the combination of both. I'll just take you through briefly what statistics of involving diabetes and hypertension in India. This is a CKD registry in India. It shows that the mean age of patients with kidney disease is around 50.1 in India, as opposed to around 20 years older in Western countries, around 70 there. The male to female ratio is around 70 to 30. Diabetes and hypertension together constitute nearly 50% of the patients who require renal replacement therapy like dialysis, transplant, etc. As you see, 31% in the CKD registry show the patients with diabetes and 13% with hypertension. And surprisingly, most of them, almost half of them present you with the stage where dialysis is required, meaning that rest of them don't even know that they had kidney problem. Staggering statistics. Diabetes mellitus in India. In 2010, we have got about 45.5 million people with diabetes. It's projected to be around 69.7 million by 2020, and about 20 to 30% of them develop chronic kidney disease, and you see the enormity of people who are likely to have kidney disease by 2020. Same thing, hypertension. The incidence of hypertension in urban adults projected to be around 20 to 40%, and in rural adults it's about 12 to 17%. And if anywhere between 15 to 25% of them develop renal failure, look at the sheer numbers of patients who will be having renal failure about 15 to 20 years down the line. And let us look at the cost of treatment for these patients once they end up with end-stage renal disease. Hemodialysis costs anywhere between 20 to 25,000 in the private sector per month. Peritoneal dialysis costs not less than around 25,000 per month. A transplant costs anywhere between 3 to 5 lakhs depending on the institution where you go for transplant in the private sector, with a running expense of minimum of around 15,000 rupees per month for immunosuppressive medications. Now, I don't think any of our patients here can afford, as the statistics say, out of around 2,25,000 patients who develop end-stage renal disease every year in India, only around 10% of them seek treatment. Only around 25,000 patients undergo some form of treatment like dialysis, transplant, or CAP. So what do? So we do screening camps biannually, and one of the World Kidney camps which we did last year, out of around 193 people screened, we picked up 3.6% with renal failure, about 5.6% of people with protein excretion in the urine, and newly detected diabetics were around 4.1%. So we make important contributions to their life by picking them up early and treating them so that the disease at least doesn't progress. These are just pictures of a World Kidney Camp which we conducted last year, and we have the kidney camp again 2 days from now on the World Kidney Day. Thank you very much.
As Prasanna said earlier, that this institution is trying to be one of excellence in pediatric care. I call upon Dr. Ramakrishnan to present his story on children with HSC.
Good afternoon to you all. I'm Ramakrishnan with interest in childhood diseases. Many of you will be surprised to know that even children are affected by kidney disease. As you see the picture where you see the knees are knocking against each other, these children we come across commonly in streets, and this is mainly because of a problem in the bone. As bones become soft as a result of which, when the children grow up, because of load bearing or weight bearing, the bones bend and the knees knock against each other. What is the connection between kidneys and the bone? Kidneys activate vitamin D. Vitamin D is essential for bone, and this activation of vitamin D happens with the help of the kidneys. And apart from that, as a byproduct of cellular reaction, we are producing a lot of acids in our body. These acids have to be excreted by the kidneys. In kidney disease, if they don't get excreted properly, the acids will dissolve the bone. So because of these two issues, there is a possibility that the bones will become soft, and this can happen. Do we have any pride in treating children having these problems? As of now, in 2015-2020, the pride is not in treatment of these problems, but in prevention of these problems. 6 months back, we had a couple of female twins in the first year of life, weighing just around 3.8 kgs, not attaining many of the milestones. We call developmental milestones like sitting, standing with support, standing without support, walking with support, walking without support. Both these children were unable to even sit without support. We have diagnosed these children at the right time, and with simple medications, supplements which can clear up their acid load, which can bring down their acid level in the body, they are now able to walk with support in just 2 to 3 months' time, and they have also put on more than a kg now after 3 to 4 months of treatment. And time and again we see children having this problem. Overnight the children will go to bed just like any other child, When they get up in the morning, they will get up with puffy face as we see in this picture. Why does this happen? When there is a problem in the filter in the kidney, they can leak protein into the urine. As a result of which the protein level in the blood will come down. Because of low protein level in the blood, they can develop swelling in the face, swelling in the abdomen, and swelling in the legs. You can see the pictures where you see the child having the swelling in the face and swelling in the legs. We have treated more than 100 children who have presented with this illness. We call this as nephrotic syndrome. And problem in children, children having this problem, they are likely to do well with steroids in at least 90% of the situations. So we have treated more than hundreds of children having these problems. So this is the summary of what I have talked to you now. Children having renal disease, they are different from adults having renal disease because the commonest cause of renal disease in children, they are different from their causes in adults. Because mentioned by previous speakers, diabetes and high blood pressure, they are the commonest causes of problems, renal disease in adults, whereas in children it is congenital malformations and inherited diseases. We take pride in diagnosing these illnesses in the earlier part of their course, in the earlier part of their life, and we try to prevent them developing end-stage renal disease, a stage at which they require dialysis. If it is not preventable, at least we delay their time to dialysis so that their growth is very well maintained. Thank you very much.
I now call upon Dr. Rajajinagar to tell you about another case of success we've had at our Institute for Transplants. More than what I will be talking, I would want all of you to look at my last slide, which is an appeal that we from this hospital are making to the general public. Renal transplantation is something that we all know of. They are there in the papers for right reasons and for wrong reasons also. First kidney transplantation was done in 1954 in Boston, and this is the recipient who's lying in the bed, and the donor who's standing next to him is identical twin brother. He died recently, 2 years back, at the age of 79. So this is what I'm going to highlight. Kidney transplantation is the natural treatment for kidney failure. Survival after transplantation is much superior to survival on dialysis. The key to success of a transplantation is post-transplant care. The medications that we have as of now has improved survival to somewhere around 95%. Very difficult to get better than this. And transplantation is a team effort. And the success that we have is that we have a perfect blend of youth and experience. Scenario one is something that you have all got in the handouts that are given to you, and this was the second scenario. This is what normally we do. Kidney is put in the lower abdomen on the right side. We don't remove the kidneys which are there in the body, except for certain specific reasons. And this is what we normally look at. If you see here, somebody with a blood group O is called as a universal donor because the person can donate it to a person with any blood group. The person with a blood group A is probably luckiest because he can receive a kidney from a person with any of these blood groups. We have two types of transplantation, living donor and deceased donor. People with a very large family are lucky to have brothers and sisters coming forward to donate kidneys, but this may not be the scenario in the coming years. So we'll have to now look at deceased donor, or people who die of stroke or die in accidents who are willing to donate kidneys as the source of organs.
Survival, I said, is much better than in dialysis. This is what we have in NU hospital. Our 3-year survival is about 87%, and this is what is the survival in the whole world. We are comparable with what is happening in the rest of the world. As I said, these are so many medications that we have which help us in making transplant more and more successful. And the word of caution, transplant is a treatment and it's not a cure. As I said, if you do not take your medicines regularly, if somebody does not come for regular checkups, they stand the risk of losing the kidneys. Not only because of problems with the kidneys on the left side, but because of problems like diabetes, bone disease, malignancy on the right side. And I said, success is basically teamwork. And in NU, we have 7 full-time nephrologists, 5 full-time urologists, 4 full-time anesthetists, 2 full-time pathologists. We have trained transplant nurses and dietitians to take care of our transplant patients. And probably that is why we are able to give success rates which are comparable to the Western world. And this is what I want you all to take home. This is something that I like very much. Please do not take your organs to heaven, because God knows them. God knows that we need them here. And a single person can save lives of up to 10 people. So let us all resolve and make sure that we, at least if we get a chance, we give a second chance to someone in this world. Thank you.
Next, I call upon Dr. Kiran Petro.
Good afternoon, everybody. So everybody has been talking about prevention or taking care of children and other things. I will talk about only intensive care. So what if a patient